Thank you for listening to the national award-winning PRS Journal Club podcast. I'm happy to present your hosts, Drs. Lily Mundy, Raj Parikh, and Kyle Sanniec.
Hi everyone, and welcome to the November 2019 edition of PRS Journal Club podcast. I'm Lily Mundy, PRS Resident Ambassador from Duke University, and I am joined by my co-resident ambassadors, Raj Parikh from Washington University in St. Louis, and Kyle Sanniec from UT Southwest. Today we have the honor of being joined by Dr. Michael Neumeister, Chairman of the Department of Surgery and Professor of Plastic Surgery at Southern Illinois University School of Medicine. Thank you so much, Dr. Neumeister, for joining us for this PRS Journal Club podcast.
Oh, it's an honor to be here. This should be fun discussing the paper.
The articles that we'll discuss can be read for free on prsjournalclub.com, including an archive of all past Journal Club articles. The article that we will be discussing is Does Staged Breast Reduction Prior to Nipple-Sparing Mastectomy Decrease Complications? A matched cohort study between staged and non-staged techniques by senior authors Drs. Karp and Choi from NYU. The authors start their paper by discussing the value that nipple-sparing mastectomy provides to patients, namely high rates of patient satisfaction and quality of life with low complication rates in ideal candidates. With oncologic indications continuing to evolve, expanding potential nipple-sparing mastectomy candidates, the authors address how to expand the pool of ideal candidates for nipple-sparing mastectomy from a breast morphology perspective, namely in patients with macromastia and ptosis. The authors describe their experience using stage reduction mammoplasty to reduce the skin envelope and improve nipple positioning prior to nipple-sparing mastectomy, allowing for a reduction in rates of mastectomy skin flap necrosis and expanding the degree of macromastia and ptosis that patients may have to be potentially ideal candidates. This is a single institution retrospective chart review comparing outcomes in a cohort of patients who underwent stage reduction mammoplasty prior to nipple-sparing mastectomy to a cohort of patients who proceeded directly to nipple-sparing mastectomy. From 2006 to 2017, the authors identified 9 patients who all underwent bilateral stage reduction prior to nipple-sparing mastectomy. Each of the 18 staged breasts were matched to 2 prophylactic nipple-sparing non-staged breasts from a cohort of 1,214 non-staged nipple-sparing mastectomies for a total matched cohort of 36 breasts. Matching was performed using known risk factors for complications, namely mastectomy indication, incision pattern, reconstruction type, radiation history, and active tobacco use. And then 2 matches were selected for each staged breast by pairing on mastectomy weights, with 1 match just over the combined mastectomy and reduction weight of the staged breasts, and 1 match just below that combined weight. After matching, there were no significant differences in age, BMI, comorbidities, or use of neoadjuvant therapies between the 2 groups. 1 case was not able to be matched by incision type. Demographics, operative characteristics, and reconstructive outcomes were compared between the 2 groups. All patients at the institution were offered a stage reduction prior to nipple-sparing mastectomy if severe macromastia and at least grade 2 ptosis existed. Nipple-sparing mastectomy was then performed at least 3 months following the reduction. In their study, they had an average time of 5 months. Medial or superior medial pedicles were preferred, and a wise pattern skin excision was used most frequently, with then a subsequent IMF incision for the nipple-sparing mastectomy utilizing the wise pattern reduction scar. Mean reduction specimens were just over 380 grams per breast, and there was 1 hematoma in this group. In the staged group, after the nipple-sparing mastectomies, 5 patients underwent a direct implant reconstruction, 3 patients underwent 2-stage tissue expander and implant placement, and 1 patient underwent an autologous free tissue transfer. The percentages of reconstructive outcomes were reflected as well in the matched group. Mastectomy weights were comparable between the groups at just over 600 grams. However, the staged group had a combined reduction in mastectomy specimen weight of just under 1,000 grams, representing a significant difference between the preoperative breast weights between the 2 groups. Major mastectomy skin flap necrosis, which was defined by the authors as necrosis requiring debridement as opposed to local wound care, was lower in the staged group at 0% versus 22.2% in the non-staged group. There were no significant differences in other complications between the 2 groups, including minor mastectomy flap necrosis, nipple areolar complex necrosis, infection, seroma, hematoma, nipple positioning, or reconstructive failure. So overall, I think the authors present a nice series of a relatively uncommon surgical indication. In their 12-year period at a pretty high-volume center, they only indicated 9 patients within their cohort of over 1,200 nipple-sparing mastectomies to undergo a pre-nipple-sparing mastectomy stage reduction. I think there are definitely limitations to their study design. However, since they relied on matching historical patients as opposed to prospectively randomizing patients. However, with the limited indications for this technique and relatively low numbers, it's potentially not feasible or maybe not an efficient prospective study for us to look at. This is also more rigorous than some of the previous research that was cited by the authors that didn't utilize a matching strategy for comparison. So overall, I think it definitely adds to our understanding of this procedure and adds to help potentially expand the indications for nipple-sparing mastectomies in a cohort of women, but again, limitations due to the small size of the study. Dr. Neumeister, I wanted to turn it over to you and hear what your thoughts were on the article.
Well, I think it's good to see studies like this that help develop appropriate ways that we can, with our surgical techniques, provide the best outcomes for patients. So I applaud them for doing that and getting this technique out there. You know, actually, since the 70s and 80s, there's been a number of studies looking at ways to deal with the immediate reconstruction of very tautic, large breasts, yet preserve the nipple-areolar complex. And even the likes of George Ade, one of the pioneers in plastic surgery, looked at immediate reconstruction rates and elevation of the nipple-areolar complex. And a lot of them had full necrosis in some patients, partial in others, and some successes where they didn't see any nipple-areolar complex. As you've alluded to, the main problem obviously is that the normal position, or the better aesthetic position of that nipple-areolar complex, is compromised by the severe ptosis and elongation of that skin paddle that it's going to be lifted on if you're going to remove all the breast tissue behind it. So I think doing a procedure where you can actually, lift the nipple-areolar complex first and then look to do the mastectomy would help with the overall result. This technique was actually described in 2012 by Scott Spear, and he had about 24 patients that he described using the similar kind of technique. So it is something rare. He had a very large breast reconstruction population. It is relatively rare. And since 2012, there's been more studies that have been trying to improve upon the overall aesthetic result and outcomes of doing some type of breast or nipple-areolar reconstruction or elevation and reconstruction. I know you mentioned the limitations, but 18 breasts is a pretty small sample size. And in fact, it's very difficult to report percentages on something that has such small numbers. So you can say 10%, and that's almost 2 patients in this study. So it's really hard to report percentages when you have such a small size. The other thing is, they did different types of reconstruction in this. It would be nice to have papers out there that talk about this exact same type of reconstruction. There was a couple of, there was a deep flap plus implant based. It would be nice to have that as all the same. They did use that matched control, but that can kind of be like, the Hawthorne effect, when when you're being studied that you change your behavior. So if you're going to do this study and you're going to review the historical database for matched controls, in your own patient population, even though you're doing this technique, you may actually do something slightly different, such as keep the skin flaps slightly thicker and therefore have better results because of this Hawthorne effect, knowing that it's going to be evaluated. The other thing they mentioned in this paper is something about using the superior medial pedicle as that's the primary blood supply to the nipple-areolar complex. I believe that's true. However, I think even in Scott Spear's article, what they did was they used an inferior pedicle. It's kind of like a delay procedure for a deep flap, actually. You want to cut various blood supplies to that. And if you can cut the major blood supply to the nipple-areolar complex, yet still keep it alive on the secondary, that may actually be better delay procedure for this technique, meaning that perhaps they should do it with an inferior pedicle, being the secondary blood supply to the nipple-areolar complex, and not the superior medial. That's just one particular thought on that. I do think that this is best for prophylaxis because of the delay in the second procedure versus in someone with, acute cancer and they're diagnosed today, waiting 3 months or 4 months or 6 months down the road to have the definitive breast surgery may not be the best. So it's probably a technique that's used best for prophylaxis than anything else. I do think a couple of things should be mentioned about nipple-sparing mastectomies, because there's been a number of delay procedures that have been tried, in order to try to do an immediate mastectomy followed by some delays. So there's articles out there that are on that. There's some that have tried single stage but use only perforator flaps or autogenous tissue, believing that if it's implant based when you do this reconstruction, that there's still a poor blood supply than if it's autogenous, where there's a constant flow of blood vessels from your flap you move up there into the new skin paddles that then remodel through somewhat of an ischemic delay phenomenon. And so I think Pontel recently described that and found that they had limited necrosis by using only autogenous tissue. And that's where whatever the D flap or S gaps that happen to be used. Finally, when we're talking about nipple-sparing mastectomies, I think articles probably should mention just general recurrence rates. Although we are talking about reconstruction, is it a bad thing to be doing nipple-sparing? And it's not. I think the rate of recurrence is slightly higher. Actually, JAMA Surgery this year came up with an article that showed that if you do nipple-sparing techniques in reconstruction, they have about a 4% recurrence rate at the nipple-areolar complex. But that did not affect survival or disease-free survival at all. Statistically, they were the same. So though you may get a slightly higher recurrence by doing the technique, it doesn't interfere with the overall survival. And you just treat it with local regional care after that. So those are things I think that should be stated as well. Overall, though, you have to applaud the authors for trying to make this procedure more reliable in the hands of reconstructive surgeons.
Definitely, and I think those are all really great points and just a really nice review for us from an educational standpoint of some of the history here. Raj and Kyle, I'm curious, I know some of you guys have been doing a lot of nipple-sparing mastectomies and direct to implant. Is this a technique that has been utilized at either of your institutions in terms of doing a staged reduction preoperatively for some of these patients?
Yeah, Lily, this is Kyle here. We have done it. It's in a very specific patient population. Usually it's in a younger patient who is maybe BRCA positive but does not have any cancer at that time. It's going to be doing a risk-reducing mastectomy, and we will do them in a staged fashion with a reduction pattern and then come back at 3 to 4 months later and do a mastectomy. Obviously, it's not as frequent as anything else. We have similar numbers to this paper, but we have been doing that more and more as more patients are coming in for the risk-reducing mastectomies. And I think that's kind of what we're trying to figure out. I think Dr. Neumeister hit it right on the head. Ultimately, I think if you're delaying their cancer treatment, and if you're trying to do this in all ptotic patients just to save the nipple-areolar complex, and I think that's the key that you need to be careful of when we read this paper. It's a very, very specific patient population because you don't want to be dealing and delaying with a cancer treatment because you're just did a reduction, so they have a more perkier breast after the reconstruction. So just making sure that we remember why we're doing the surgery to begin with. But I think in the right patient, I think it's a nice option.
Thanks, Kyle. This is Raj. I completely agree with Kyle and Dr. Neumeister. I think this is a great paper because it really talks about how to just improve outcomes, even if it's just for a small group of patients. And obviously from a very thoughtful group that does a lot of nipple-sparing mastectomies, has written really extensively about it. So always great to read a paper from that group. And I think it's completely true that this population really, I don't know of anyone that would wait 3 to 6 months with a diagnosed cancer to do the mastectomy. So I think we're really just talking about patients, like Kyle said, prophylactic nipple-sparing mastectomies, and probably in younger women that do not want flap reconstruction, to do this as a staged approach. I agree with Dr. Neumeister and what he had mentioned, that Pontel paper, and then I think a few years ago, Dr. Delacroix and their group in New Orleans had a paper as well on nipple-sparing mastectomies and allowing you to do a secondary mastopexy. And we've done a few of those where we will do a deep flap and then come back and do a secondary circumvertical mastopexy, and had no issues really with nipple necrosis in those patients that are really ptotic at the time of mastectomy. We've done very few staged procedures that they describe in this paper, less than a handful that I can remember. And the primary reason is just that, a lot of the patients that we're treating are cancer. And now with nipple-sparing mastectomy, it tends to be a younger population, the prophylactic patients. and at least the ones we've done, not as many of them have these large ptotic breasts. So, we've done a few as well where we're doing reductions at the same time with different patterns. And, I think those are, like the authors mentioned, there's a increased risk there. Dr. Rourke had a paper as well that, cited around 15 to 20%. I think that's definitely true, but it's such a small subset of patients that require these reductions at the same time that, it's just anecdotal complications. I couldn't really give you a rate on them doing it simultaneously. So I definitely think this is a great paper and there's a need for these operations, but it's going to be limited to a really well-defined population.
Dr. Neumeister, maybe a potentially more relevant application of these concepts for us is also when a patient presents to us with a known cancer who's had a previous breast surgery that has, maybe a previous reduction or at least a mastopexy, a previous circumarular incision. We have some breast surgeons at our institution that like to sort of stage or delay these patients, a week or two in the setting of if they know they're going to do an implant-based reconstruction, make a small incision, widely undermine, take the, retroareolar, biopsies and make sure that that nipple will survive before they perform the mastectomy and place an implant. Do you think there's other strategies, us as trainees should be thinking about, given the recent successes of doing some of these procedures, previous reduction and then doing implant-based reconstruction? How should we think about these patients who present to us?
That's a good question to look at going forward if they've had other types of breast surgery. I think the type of surgery may mandate or dictate what you end up doing. I think delay phenomenon, if you give them a couple of weeks, it's not going to interfere with any type of cancer diagnosis or treatment. And by doing something that's going to improve upon the blood supply, we do it for various other flaps. A lot of folks might do it for the deep flaps, just for general reconstruction, just to acquire one more angiosome or two more angiosomes within certain areas. And here, we're specifically looking at the blood supply of the nipple-areolar complex. So I do think using previous incisions to do that is worthwhile doing. I also think, other things is we should be taking some type of frozen section at the time of reconstruction. When we're doing that, or at least the oncology surgeon, someone should be doing that right underneath the nipple-areolar complex so that going forward, you don't see any cells that are cancer cells in there as you've done your reconstruction. So it's sort of like, I know I'm starting at ground zero, at least close to ground zero as we can be. So I think that as a part of the procedure, someone should do the tissue below the nipple-areolar complex, take a frozen section, and dictate that in your operative note to say this was done, there's no evidence of cancer, and just say going forward, we proceeded with no other evidence of cancer. So delay is a good thing if you get in there, and you only have to delay it for a couple of weeks using previous scars. I do think that previous surgery on the breast does rearrange the vascular architecture in there, so the results are certainly different than if you haven't done that at all. And the only other thing that was mentioned earlier from Frank De La Cruz's group in New Orleans in that paper, those were all using deep and S-gap and perforator flaps, and it was a large study of over 116 patients or so. That one really set a tone that if you use autogenous tissue in this reconstruction, it may actually lend itself to improving the blood supply to those skin flaps. That probably needs to be proven. That was their end conclusion, but it's food for thought.
Well, with that, I think we'll end the discussion of this article. Thank you, everyone, for a great discussion. If you like this podcast, please feel free to share with your colleagues and friends and rate us on the Apple iTunes Store. Also, remember to tune into the other two articles that we will be discussing on this month's podcast. Finally, please join us for our monthly journal club on Facebook, where we will be able to interact directly in real time with this month's selected articles' authors. Go ahead and like the Plastic and Reconstructive Surgery Facebook page if you've not done so already. It is there where our monthly journal club takes place. And once again, thank you so much, Dr. Neumeister, for joining us.
It was a lot of fun. Thanks for doing this.
Thank you for listening to the award-winning PRS Journal Club podcast. Be sure to read all of the articles being discussed, including some of the classic pairings from the archives, for free on prsjournal.com.